Thank you, everyone, for joining us. I am Lise McDowell, Market Development Director with NEURELIS, and I have the pleasure of honoring Dr. Raman Sankar from UCLA to be presenting on VALTOCO, To the Rescue. As many of you know, Dr. Sankar is a previous chief of pediatric neurology at UCLA Children's Mattel, who's recently given up his reign as the chief honcho, but however, he still is very esteemed and still working very closely with the fellows at UCLA. And he has all sorts of other accolades, but without further ado, I will turn it over to Dr. Sankar.
Thank you. And after that nice introduction, I want to tell you I would just as soon be standing down there a little closer, but we don't have a remote to advance the slides. So here we are, and my presentation today is to introduce you to this product. Some of you may already know it. It's called VALTOCO, which is a nasal therapy, a spray for rescue from seizures. Okay, so this is, you can see an illustration of it. The device looks a lot like many products that are used in neurology. There are migraine treatments, seizure treatments. Yes? Oh, okay. I thought there was a comment. Okay. Anyway, so this is the product that permits you to terminate seizures and prevent recurrence of seizures with a spray of diazepam. Yes, sir. Oh. Is it working now?
Yes.
Oh, good. Thank you very much. Okay. So, this particular disclaimer is important. When we go to these forums, you have to understand, even though we are physicians and some of you may have family members who are patients, this is not a forum for medical advice. Okay, we don't make treatment kind of question answers here. So just know that this is to understand the product, not to try to bring up specific patient issues of a family member. Okay, so VALTOCO is the brand name for this device that you can see that contains the seizure rescue medicine called diazepam. It is for short-term treatment, not for everyday use. It is in specific, it's been approved by the FDA for seizure clusters. Seizure clusters are basically also called sometimes acute repetitive seizures. And the product is approved for patients 6 years and older. And so the episodes of frequent seizures, we'll talk a little bit about what they are and why you need rapid intervention. Then we'll talk about having a plan about managing episodes like this. We'll talk a little bit about details about the product itself, and then we'll finally finish with some patient resources available. Okay? Episodes of frequent seizures are basically 2 or more seizures that occur in one day that are different than the regular seizure pattern. Okay? Now, people call it by a number of names, such as shown on the right, such as breakthrough seizures, right? Repetitive seizures. I think if you're a family member, you know typically there's a number of situations where they can occur. One of the common circumstances is patient missed a medication, right? Sometimes they missed a medication because they went to the pharmacy on Friday and they told you they just don't happen to have some particular type of medication. They have to get it from the wholesaler. It'll be Monday before you get your renewal, right? Typical scenarios. Other times, in many of my younger patients, it's due to an acute febrile illness of some sort. And other times it may be hormonal. somebody has exacerbation during, let's say, a menstrual period or something like that. So there's a number of reasons why this could occur, okay? So they can be either focal onset are sometimes also formerly called partial seizures, or generalized, or a variety of other seizure types, okay? And it can occur in children, adolescents, adults, or the elderly. And in the United States, we have about 3.5 million people with epilepsy, and at least 170,000 or so experience these episodes of frequent seizures. These estimates are difficult to make because not everybody gets counted very easily, so the number could be somewhere in that neighborhood. But the key issue that we want to describe is that a large number of people with these circumstances do not treat them adequately, right? Only 1 in 5 seem to use rescue medications for their episodes of frequent seizures. My own suspicion is coming from pediatric neurology. The uptake of rescue therapy is relatively high in young people and relatively low in adults. That has to do with the history of the early medication that became available for rescue as a rectal gel that was easy to use in a baby or a toddler, and bigger the patient becomes, the less the uptake of that rescue treatment is, right? But the key thing is they are unpredictable. 3 out of 4 people living with epilepsy worry about it. They can, 4 out of 10 continue to have them regardless of the fact that they are taking regular seizure medications. And again, with the regular medications, you have a limitation on how much medication burden you can handle and function with all the other activities you want to do. So typically, a physician may not choose to continually escalate it till you have 0 seizures. Because if the rare seizures occur only due to unexpected provocation or circumstance, it makes sense to be on a level of medications where you can function, but you have access to rescue, okay? So it allows you then to have the earliest possible treatment. So prompt intervention is critical because the key factor here is to avoid visits to the emergency room. So the average waiting time before treatment is about, yes? Oh, okay. About 42 minutes, and the average travel time to the hospital could be almost an hour. And people who have rescue medication make far fewer trips to the emergency department, and they are less likely to be injured from their seizures. So it allows you to take control of your seizures so you can treat the seizures as soon as they occur. Okay? So this device is shown here again, and it's fairly simple. Let me see if the cursor shows there. Basically, this part goes in the nose. This is the part you squeeze. This is exactly the device used for a number of products, including some migraine abortive treatments, right? And patients should have a seizure action plan. My patients of school age, they tend to have a seizure action plan because the schools usually expect that you would file that with them, right? So you have to work with your doctor, neurologist, to develop an action plan where there is information about the type of seizures you have and how you can be helped, when and how to use the rescue medication, and then when it is that you would actually do the 911 for emergency assistance. Okay? And this is just an example of the form that you can see, and you can get it from the Epilepsy Foundation, from the website. If you just go Google for seizure action plan, it's likely to give you a variety of links, such as the Epilepsy Alliance. They're very easy to come by. Okay? And then you can start it, you develop it. If you don't have one, you should do it right away. And you can update it, especially for growing people, the dosing requirements may change. And then you can share it with others. It's good to have it in school, potentially place of employment, other family members, etc. Okay? So this is what the device looks like again, and it has been indicated for 6 years and older by the FDA, and it does not require a specific type of licensed medical personnel. It's really used by home, by family members, relatives, right, siblings, whoever is appropriate, ready and available. And we have experience with this medication for more than 20 years because the ingredient in VALTOCO is diazepam, that is long known as a seizure terminating drug. And then it was approved, in the 90s for use as a rectal gel. That was named at that time Diastat. Now it's just called DRG generically. And so this is a nasal spray approved by VALTOCO for these seizure clusters. It is small, discreet, easy to pack. Many of my patients who transitioned from rectal gel to this always inform me how much more comfortable they feel traveling, for instance, or being on a plane, right? Or having to use it in the classroom. It is just much, much easier. It is safe and reliable. Very few people actually have any kind of nasal discomfort or change in taste. Nosebleed, it's a funny thing to talk about because for those of us who practice pediatric medicine in Southern California, far more than 2% of the people have nosebleeds, particularly on a day like this when we have Santa Ana winds and the mucous membranes are dry. So when you get this, you also get a little saline with it, right, as a background. So you're probably having fewer nosebleeds than if you didn't have a spray of Diastat VALTOCO. So it's packaged easily and the instructions are available. This is important. It comes in different dosages, 5, 10, 15, or 20. And as I will show you downstream further, the 15s and 20s are split into 2 dispensers, right? So for the smaller dose, 5 and 10, it's a single one nostril use. For the higher dose, depending on the age and weight of the patient, if you graduate to 15 or 20 milligrams, you're going to do 7.5 in each or 10 in each, okay? And everything you need to give the full dose is in 1 blister pack, meaning if you exceed the 5 or 10 and go to 15 or 20, that blister pack will have 2 units in it, 1 for each nostril, okay? So typically, if you get a prescription for 2 doses, for those in the higher levels, you'll actually have 4 dispensers. 1 dose is 1 blister pack, okay? And the instructions are very straightforward. They are actually easier than having a lot of complicated figures, but you can see on illustration 2, the nozzle and the plunger as I showed you. You simply insert and squeeze, okay? And if you are using 2, 1 goes in each nostril, okay? So it can be administered by anyone. There is no assembly required. It says no priming. I'm going to elaborate a little bit because at one time they would say no assembly required, no priming required. Actually, you should never prime because people who use nasal decongestants, they get these bottles that have multiple doses and they often go into the habit of triggering it in the air to make sure it's working. Never do that with VALTOCO. You know why? There is exactly one dose in that dispenser you have in your hand. So this is an emergency. You want to make sure the medicine gets in the patient's nose, not in the air, because if you squeeze it, you lost it. There is no more medicine. So know that it is 100% reliable. You don't need to check it in the air. You should directly use it on the patient. Okay? It's very easy to carry, does not require refrigeration. Okay? There are resources available for you. It's available at retail pharmacies. There are copay savings program and patient assistance program. You can very easily apply by simply going to myneurelis.com. But even if you Google and type in VALTOCO, below that Google is going to show you that link for neurelis.com if you don't remember the company's name. Okay? And there are demo kits available. Typically your doctors have it and they can kind of walk you through it if you have any concerns about it. You can also get them again from valtoco.com or by calling that 866 number, right? And you can get personalized support. There is potential savings and support available. Nurse educators are available. I know my nurse practitioner helps with that. And there are demo kits, seizure action plan template that you can get, okay? There's also connection to advocacy groups, and then there is a booklet called The Path Towards Prepared that you can obtain that has tips, insights, words of wisdom from people who live with epilepsy and are willing to talk about it, okay? So all these resources are available from the website, and you can, again, you can start a conversation about it, talk about your options, and again, there is the doctor discussion guide you can disclose, right? So important thing to know, 6 years and older, you have this wonderful rescue product that's extremely easy to use, can be administered by anyone, more than 20 years of experience. And then some of you may have questions, but I will go ahead and answer one likely question, because that has come up in my practice, that sometimes people say, you know, I'm not sure my youngster is breathing well during a seizure. What if they can't really inhale? That's a common question. Most important answer, they don't have to inhale. This is not inhalation therapy, okay? Some medications are used as inhalation therapy, but inhalation means absorption in the lung. This particular spray, the particle size of the spray is too big for inhalation. It is designed for absorption by the mucous membrane in the nose. So it requires no cooperation from the patient. All you need to do is spray it, the magic happens, okay? It's absorbed in the mucous membrane. It's absolutely not for inhalation, right? There are some safety information. They are probably particularly important for doctors to talk to you about. It's a controlled substance. There is a potential for abuse or dependence. The government wants us to tell you that, but I'll tell you, I've been practicing neurology for about 35 years. I have not had an addiction problem to people using rescue therapy or, for that matter, any seizure medication. We actually worry much more about people not using the medication and getting into trouble than using medications properly, okay? So this is just something I have to tell you. I have not seen this as a problem, right? And of course, another important warning, again, it should not be combined with other central nervous system depressants, whether it be alcohol or opioid medicines. Again, as a pediatric neurologist, for the most part, my kids usually don't have a martini before dinner. before they have their seizure, and they're generally not doing opioids, okay? But opioids are a politically sensitive topic these days, right? Everybody wants to talk about them, right? So not to be mixed with fentanyl is the message, okay? So, moving on, again, physical dependence and withdrawal, yes, this used to be a problem when people used recreational benzodiazepines. I really do not know of a case of physical dependence and withdrawal from medical use of benzodiazepines for the treatment of epilepsy, okay? And for the same reason, I don't know that anybody has documented a case of suicidality from use of rescue therapy, right? These are necessary to tell you about, but they are, unfortunately, I find them a little bit of a distraction from the real issue. Is if your family member is having a seizure, please treat it promptly to avoid complications from seizures, including injury, potential cardiac arrhythmia, aspiration pneumonia, fall and injury, or long delay in treatment in an emergency department. Okay? So, other important safety information includes allergies to diazepam or an eye problem called narrow angle glaucoma. I'm going to override that and tell you that nobody in neurology will tell you that if somebody with glaucoma is having a seizure, you should just let them seize. Generally, if they have glaucoma, they should be under treatment by ophthalmology, right? That should not prevent you from treating an acute onset seizure, okay? So you just have to know that there could be an interaction, but it is certainly not an indication that you will not treat, okay? And then before using it, of course, you can review all your conditions with your doctor, and they can make that judgment for you whether you may use this safely. But in my life, I've never come across any situation where a neurologist told a patient, just let them seize, don't treat it. Okay? All right. Read the instructions. Again, they are relatively easy to use. And what should you do after you give the VALTOCO? That is something we can talk about, right? You should stay with the person and you should observe them closely. Make note of the time you gave the VALTOCO. If things are not coming under control, you may call emergency department. They would want to know that you administered this. They would want to know when you gave it, how much you gave it, right? And again, throw away the used VALTOCO so it doesn't confuse anybody. And if needed, a second dose can be given at least 4 hours after the first dose. We have found that in experience, post-marketing experience, the vast percentage of patients have not required more than one dose. Something in the order of high 80s, 87% or so, have needed only one dose. Okay? And you certainly should not give a second dose if you have concern about the person's breathing. Okay? And so do not use for more than one episode every cluster every 5 days. And don't use for more than 5 cluster episodes in a given month. The reason is if people are having seizures that frequently, their baseline regular maintenance medication may need to be adjusted. They may need other approaches. The doctor may want to talk to them about what other options exist beyond medications. Okay? And so some of the common side effects, feeling sleepy or drowsy, we find that as doctors quite acceptable. We expect that if you get a benzodiazepine enough to terminate seizures, that you will probably be a little drowsy. But we have also found that recovery is actually very, very good. fairly rapid. And then headache or nose discomfort could occur. They are not particularly, to me, not common. In my population, people don't come and complain about those. They're very happy to have stopped the seizure, okay, and prevent recurrence. So I'm going to stop there. Ran through some of those slides quickly, so you'll have some time for questions. Okay? Right. Anybody has questions, comments? That includes, even if you're already using it, you want to bring up any issues that you have encountered? Yes?
Hi. My son uses VALTOCO as a rescue med.
Uh,
Is there an expected period of time as to when it would work after you administer it? Because sometimes it seems like it takes upwards of a minute.
it can take more than a minute. You know, usually the average seems to be about 4 minutes.
Okay.
Okay? Because, you know, you have to have the absorption. That can vary in people depending on the time. But typically, you know, 4 minutes seems to be.
Okay.
If people are able to administer it in the first minute or so. Okay? But sometimes, you know, people may delay the administration simply because you gave the instruction to your older son and he forgot where you have the VALTOCO at home or something like that. So if there's a delayed administration, there's going to be a delayed cessation of seizures.
And do you always recommend to wait 5 minutes from when the seizure starts?
No, I do not. I'll tell you how that advice came about many, many years ago. Long time ago, there was a significant study done at Albert Einstein by Professor Shinnar. And he kind of looked at the probability of the seizure stopping on its own. Okay? What he found that was that majority of seizures stop in the first couple of minutes, anywhere from 30 seconds to a couple of minutes. The probability that it's going to stop is very high. However, if the seizure goes past 5 minutes, somewhere in the 5 to 10 minute window, right, the probability that the seizure will stop on its own without an intervention changed very dramatically. The probability curve went like this, low to very steeply. There was a point of inflection. That's why people used to say, don't let a seizure go past 5 minutes. But Professor Shinnar also showed that people who are known to have a prolonged first seizure are at high risk that their future seizures may be long. So sometimes the family has a very good idea about the pattern. Right? They don't always worry because they say, yes, he has frequent seizures, but they stop in a few seconds. Right? He has these quick flashes. Other times, they would say a lot of times the seizures don't stop. We panic, we call 911, we end up in the emergency room. So if you feel your family member is generally not having seizures on a daily basis, and if you feel that most of their seizures tend to be long, you definitely don't have to wait for those 5 minutes, right? The other reason you may not want to wait is because you realize this is probably going to stop on its own in a couple of minutes. But let's say the family member has an acute illness, or it's a known expected period of turbulence, such as a menstrual period or something like that. Or you just have an ominous thing that, you know, they've had diarrhea 3 times already, and now they had a seizure, and you're afraid that this is not going to be a good day. So remember, the biggest indication from the FDA is actually for recurrence, right? So from that point of view, you might as well use it rather than wait 5 minutes.
You can use it right away.
You don't have to, yeah.
Okay.
Yeah, the 5 minutes was more like, in the days of the rectal gel, it often took time for them to actually prepare the patient, prepare the product, etc. Okay.
Thank you.
That's a very good question though, because I think a lot of doctors are in the habit of saying 5 minutes. It really goes back to that paper on probability of seizure ending with or without intervention. Otherwise, there's nothing magical about it. It did not imply that it's okay to have several 3-minute seizures, right? Yeah. Any
I
other?
have a question.
Yes, please.
We've had some success with using the medications, and I've noticed though my daughter's had a couple of seizures while sitting up. And is it okay to administer that medication in the upright position? 'Cause obviously, some of the discharge comes out, and
Yeah.
I'm always worried about not getting enough in there. A couple of times, like the lady said, we had where it seemed like the seizure went a full 2 to 3 minutes,
Yeah.
and then it finally stopped. So I wasn't sure if it really, but most of the time we have success with it.
Yeah, that's a good question. Let me repeat the question in case everybody could hear. He wanted to know, is it okay to administer to a patient who is actually having a seizure sitting up and not lying flat, right? That's often the case, right? Because people don't always have seizures lying down. The important concern is whether the medicine will come down. So that goes back to 2 or 3 important concepts. Number one, in other talks when I talk about VALTOCO to doctors, I go on and on about it, which is the very special formulation of this product. This product is formulated in a very concentrated form by using a special type of system that it's in a very, very small volume so that the spray doesn't drizzle down. That's one of the main aspects by which this product succeeded. Okay? So there is not a lot of risk of it coming down. It's entirely safe to administer it to a person who is vertically positioned. Okay? And it will still get absorbed and function well. However, depending on the circumstances, if you go to acute seizure management guidelines, let's say given to the school teacher by the Epilepsy Foundation of America, they'll say if a kid is having a seizure, put them down and turn their head to the side, make sure the airway is clear. That is all true. But generally, those who are dealing with a family member at home are more than familiar with managing all those. But if you are not in any prolonged convulsive thing, they're sitting there and you feel like the small seizure is a harbinger of things to come and you want to treat it, you may treat it safely. Okay? Yeah. Anything else? Yeah.
Thank you. My son has been having back-to-back grand mal seizures where he'll have one and then within an hour and a half he'll have a second one. Can you do the VALTOCO administration twice?
The guideline from the FDA is that you can use a repeat dose after 4 hours. Okay. So if you gave a full dose and the patient is actually having a grand mal within that duration, it is appropriate to call 911 for help. Okay? Because if you gave a repeat dose too early, there is a potential risk that you may not be able to manage the airway if they are not able to breathe well. The thing is, if the emergency personnel arrive, they are probably going to use a benzodiazepine, possibly even VALTOCO, right? but they are equipped to handle airway problems. Whereas as a parent, you may not be.
Right.
Yeah. Anything else? Yeah,
I'm
Lucia.
curious to know if anybody has used the VALTOCO, the copay savings program. Because I know when we got, through my insurance, it was $1,700 for the spray, is what we pay.
Through the insurance?
After insurance,
$1,700?
$1,700.
Where do you live?
Kentucky.
Ah, Kentucky, that's where my wife is from, sitting there in the back. I don't know how the Kentucky, is this Kentucky Medicaid?
No, it's
Private insurance?
state, I'm a teacher.
Ah, okay. Because, you know, I don't know the reimbursement issues very well. Your local representative may be able to help you. It should not cost you $1,700 for rescue. There has to be a way, okay? Either through patient assistance or the insurance company, it doesn't make any sense that they would, because it's more expensive for them to pay for ER visits. Yeah, go by the booth for NEURELIS in the exhibit area, they'll help you.
Actually, you maybe just didn't meet your deductible for medication, and that's why it was so high, but they did.
It's met now.
But they didn't apply the copay card. That's what it's meant for. So they run it through your insurance, and it comes out to be that expensive, which I've never heard of it being over 600, so I'm kind of confused. But, then they run the copay card through, and that will buy it down to, and usually it's twice. So it would, I just think maybe the pharmacies would know how to run it, and you dip and run through the insurance firms, and then whenever they don't pay, then run it through the copay card, and then you can use that copay card over and over and over, every time you bill it, and it tries to get the deductible as well.
But have a talk, because I don't think everybody can hear you. But if anybody has questions about reimbursement issues, be sure to stop by the booth in the exhibit area, they can help you. I can guarantee you that it should not cost that kind of money for seizure rescue. And my experience here in California is when we prescribe rescue therapy, they get it. Okay? Yeah.
Yeah, we actually have Kaiser. We live here in California, and it's nowhere near that much. I think it's under $100. So yeah, it's not that much. Yeah.
Yeah. For people here on, you know, Medicaid, our version is called Medi-Cal, or some of our kids have California Children's Services. They generally have full coverage, actually. The CCS people don't even have a copay, to my knowledge. How are we doing with it? I think we should be clearing the room for somebody else, right? Yeah. Thank you all for coming.